We started. Hello, everybody. Today we'll be discussing about the disorders of pigmentation. Basically, the pigmentation of human skin is due to the pigment called as melanin, which is formed by melanophages occurring inside the melanocytes, which are mainly located in the basal layer of the epidermis amidst the keratinocytes. So depending upon the size of melanophages, the melanosomes and the melanocytes, the melanin pigmentation production depends on these few factors. And depending upon these factors, the disease are classified into disorders of hyperpigmentation in which there is an excess of melanin, and disorders of hypopigmentation where there is reduction or even at times absence of melanin pigment. So the skin of the color is the color of the skin is determined by three factors: the melanin, the hemoglobin, and the carotenoids, of which melanin is the major determinant. It is synthesized by the melanocytes within the melanosomes, and then it is transferred to keratinocytes. Uh, the genetical color which a person possesses is called as the constitutive skin color, and genes such as SLC45A2, GRM5, HERC2, CA2, etc. are responsible for the determination of the constitutive skin color. The skin color which a person acquires in the lifetime, induced by sun exposure, hormones, and other external or internal factors, is called as the facultative skin color. The melanocytes are dendritic cells which are derived from the neural crest. They then later on migrate to the epidermis. One melanocyte is connected to about 36 keratinocytes by dendrites, to which it supplies its melanin. And this is called as the epidermal melanin unit. Melanin is synthesized in organelles called as melanosomes, and these melanosomes are then transferred to keratinocytes, to dendrites by a process called as apopopation. Apopopation is a process wherein the part of the two membranes fuse together and the melanin is transferred from melanocytes to the keratinocytes. So this is the pathway of synthesis of melanin from tyrosine. Tyrosine is converted to dopa with the help of an enzyme called as tyrosinase. Thereby, later on, it is converted to dopaquinone. This dopaquinone is passed through two pathways. One is the dopachrome pathway, and other is the cystinyl dopa. Or the dopachrome pathway, eumelanin is synthesized, whereas the second pathway of cystinyl dopa, a pheomelanin or the red melanin, is synthesized. Skin pigmentation has far-reaching social and psychological implications. White people strive for tanning, and brown and black people strive for a lighter skin. So melanin pigmentation disorders are important for medical and cosmetic reasons. We classify them into disorders of hypopigmentation, where there is reduced or absent pigment, such as vitiligo, pityriasis alba, etc. The hyperpigmentation disorders, uh, such as the epidermal pigmentation disorders and the dermal pigmentary disorders, and other points of classification, such as it can be a pigmentary disorder can be localized or generalized. It can be along a segment, a neuronal segment, or non-segmental, or a blastoid or reticulate pattern. And presence of both hypo or hyperpigmentation intermingled, leading to a dyschromic or a mottled appearance. When we see a patient of pigmentary disorder, the most important part is the history, the onset, if it is before birth, during birth or infancy or later, the cause, whether it is due to sun exposure or drugs or occupation, and other systemic complaints. How to approach a patient clinically now? After the history has been taken, then comes the part of examination, of which inspection is the most important and the foremost. There are so many things that should be taken into consideration. The color, whether it is hypopigmented or depigmented or brown or slate gray, whether what's the shape, what's the margins, whether the margin is serrated or it is scalloped, whether it is symmetrical, whether there is a appearance along the line of trauma that is known as the Carboner phenomena. Examination parts include sensation check to rule out leprosy, Hansen's disease, dermatoscopy, Wood's lamp examination, histopathological examination. Several stains such as silver stain or Mason Fontana stain are used to see the melanin pigment deposition, whether it is in the epidermis or dermis, and DOPA reaction, of which helps us to know whether the melanocytes are increased in number or they are same, or there is an increase in the size of melanophages and the melanosomes. So the hypopigmented or depigmented disorders, now talking about them, they are classified according to the genetic and developmental. Albinism, nevus depigmentosus, nevus anemicus, halonevus. Endocrine disorders such as hypothyroidism and hypopituitarism, nutritional deficiencies such as vitamin B12 deficiency, protein deficiency disorders such as kwashiorkor and malabsorption states, post-inflammatory disorders such as pityriasis alba, eczema, psoriasis, pityriasis rosea, lupus erythematosus, morphea, scleroderma, and bullous dermatosis can lead to hypopigmentation or sometimes depigmentation due to total loss of melanocytes. Other causes being infections such as leprosy, pityriasis versicolor, candidiasis, post-Kala-Azar dermal leishmaniasis, chemicals and drugs such as phenols, arsenicals, hydroquinone, and steroids, physical trauma, burns, post-dermabrasion, post-laser, miscellaneous reasons being idiopathic guttate hypomelanosis, vitiligo, mycosis fungoids. All these are the reasons that might lead to hypopigmented or depigmented lesions. First of all, speaking about what is albinism. Albinism is a disorder where there is total absence of melanin pigment. It involves skin, hair, and eyes. All the areas where there is color due to melanin are involved in albinism. The reduced pigment in the eye is universal. Mostly it is autosomal recessive mode of inheritance. The mutations in tyrosinase genes, OCA2, the tryptophan 1, and the SLC45A2 genes are the main causes of oculocutaneous albinism. The absence of pigmentation from the birth, and it leads to photophobia, reduced visual acuity, nystagmus, sunburns, and in later life, skin cancers. Certain diseases such as Hermansky Puglag syndrome, Chidiac-Higashi syndrome should be ruled out before labeling a person as albino. The most important part in later life is protection of eyes and skin by sunglasses so as to avoid any chances of ultraviolet induced skin cancers. Vitiligo, basically this topic is dealt separately because it is a huge topic, but just an overview is being dealt with here. It is a common pigmentation disorder and The exact mechanism is unknown. However, several theories have been postulated: the neuronal mechanism, the toxic mechanisms, several of them. But all these are hypothesized. No theory is substantiated with concrete evidences. So immune-mediated melanocyte destruction is the most commonly proposed mechanism wherein there is a destruction of the melanocytes by body's own immune system, so-called the autoimmunity. The key mechanisms and mediators involved in melanin destruction are oxidative stress, CD8 plus T lymphocytes, the HSP70I gene, the interferon gamma, chemokines, etc. The clinical classification has been made in several ways. The most common is the segmental and the non-segmental phenotypes. The other is depending upon whether it is localized or generalized vitiligo. Some classifications are also made depending upon the morphology, whether it is a monochrome, a trichrome, or a quadrichrome vitiligo, depending upon the islands of hyperpigmentation, hypopigmentation, and depigmentation that are present in different parts of a vitiligo macule. Treatment mainly rests on mid-potent corticosteroids as they suppress the immune response going on. Systemic therapies include steroids and other immunosuppressants such as cyclosporine, azathioprine, methotrexate, etc. Phototherapy, narrowband, UVB, psoralenes and ultraviolet A, excimer lights and lasers have also been widely used in treatment of vitiligo nowadays. Tofacitinib and ruxolitinib are the newer agents which are being used in treatment of vitiligo. The vitiligo non-responsive to therapies, not progressive, and in difficult to treat areas are treated better by surgeries of different types such as punch grafting, mini punch grafting, suction blister grafting, split thickness grafting, non-cultured melanocyte transfer, and melanocyte culture techniques. Another disease is the Griscelli syndrome, which is also known as the lighter hair diseases, which is autosomal recessive in inheritance. Several genes such as MY05A, RAB27A have been implicated. There is a perinuclear aggregation of melanosomes in the melanocytes, and clinically this disease manifests as congenital hypomelanosis and hypopigmented hair. The eyes are normal, and this helps us to distinguish this from albinism because there the hair, the skin, and eyes all are affected. Death may occur due to various complications and systemic involvement. Multidisciplinary approach by neurologists, hematologists, and dermatologists is necessary. But in all forms of these disorders, the most important thing that needs to be done is sun protection so that the complications are taken care of. The other, the next part of the disease is the Chiari-Higashi syndrome. These all diseases are those which manifest as lighter hair disorders. Autosomal recessive inheritance, CHS1 gene, the pathogenesis lies in defects in the function of neutrophils, platelets, the cytotoxic and the natural killer cells. And histopathologically, we see giant inclusion body in all granulated cells. So the clinical features include oculocutaneous albinism, recurrent pyogenic infections, enhanced tendencies to bruising and neurological dysfunction, and lighter colored hair. The management rests same as the Griscelli syndrome, wherein the most important part is to protect the skin from ultraviolet rays that might lead to skin cancers. Baldism is an autosomal dominant condition which is mainly due to the c-KIT gene. There is defect in melanoblast development, proliferation, migration, or survival, decreased receptor tyrosine kinase signaling, and finally decrease in the melanogenesis. It presents as congenital, sharply demarcated, symmetric, depigmented patches over the frontal scalp, forehead, ventral chest, abdomen, and extremities. The Waardenburg syndrome is a rare, genetically heterogeneous group of diseases, and mainly 6 specific genes: the PAX3, the MITF, the SOX10, EDN3, EDNRB, SNAI2 genes are involved in Waardenburg syndrome. The white forelobe, which presents as a small patch of depigmented skin with depigmented hair on the front of the scalp, the broad nasal root, congenital sensory neural deafness, partial or total heterochromia of the iris, lateral displacement of the medial canthus of the eye are important features that help us to identify the Waardenburg syndrome. Limb defects and Hirschsprung's disease are also known to be associated with this form. Tuberous sclerosis, it is an autosomal dominant disorder where there is mutation in the TSC1 and the TSC2 genes. It manifests as hypopigmented ash leaf-shaped macules which develop early during the life, the angiofibromas, the shagreen patch, and the subungual fibromas. The other pigmentary changes that occur mainly in this group of disorder is generalized guttate hypopigmented macules, also known as confetti hypopigmentation, polygonal hypopigmented macules, the thumbprint shaped, and cafe au lait macules. Epilepsy, renal and brain hematomas are very commonly other conditions associated or other problems encountered in the patient with tuberous sclerosis. Nevus depigmentosus. It's a hypopigmented birthmark which is congenital, stable, non-familial inheritance, irregular geographic margins, and a quasi-dermatomal distribution is seen in cases of nevus depigmentosus. It should be differentiated from vitiligo. The margins of nevus depigmentosus are serrated, whereas in vitiligo, we see that the margins are scalloped. The reason of developing a nevus depigmentosus is block in transfer of melanosomes from melanocytes to the keratinocytes. The management rests on surgical techniques and excimer laser. Nevus anemicus is not a true hypopigmentous disorder, but it is mainly due to a vasoconstriction and ischemia in that particular part. This can be differentiated from nevus depigmentosus by pressing a glass slide over the area. The nevus depigmentosus stands out from surrounding skin, whereas a nevus anemicus merges with the surrounding skin on pressing the glass slide. This is because the blood vessels are compressed by the slide and resulting in an ischemic response in the surrounding skin as well. The cause being increased reactivity of the alpha-2 receptors of the vasculature to catechols, resulting in persistent vasoconstriction. The other disorder of hypopigmentation is hypomelanosis of Ito. The etiology being genetic mosaicism. Clinically, it presents as macular areas of hypopigmentation following the lines of Blaschko. The shape being whorled V or wave pattern, mental retardation, epilepsy, learning disabilities, vesicoureteric reflux, and musculoskeletal deformities are associated defects occurring along with the hypomelanosis of eye too. Pityriasis versicolor is a superficial dermatophytic fungal infection caused by Malassezia furfur. It is mainly common after puberty when the sebaceous glands become active, occurring mainly over the face, the neck, and the upper trunk. This disease manifests as non-pruritic, hypopigmented, hyperpigmented, or erythematous lesion with fine briny scale, which become prominent on scratching. During summers and humid climates, the lesions are more common. Treatment being topical and systemic antifungals. Leprosy or Hansen's disease is a bacteriological disease caused by Mycobacterium leprae. There are several forms, their classification depending upon the morphology of the lesions, the tuberculoid, the borderline tuberculoid, the mid borderline, the borderline lepromatous, and the lepromatous leprosy. The hypopigmented lesions are common mainly in the tuberculoid variant and the borderline lepromatous variant. The hypopigmented lesions in leprosy should be examined for sensation of touch, pain, and temperature. And the treatment rests upon the multi-drug therapy or the paucibacillary therapy depending upon which spectrum of the disease is involved. Pityriasis alba is an endogenous eczema occurring mainly in the children, usually atopics with dry skin and manifest as ill-defined hypopigmented macules with scaling mainly over the face, the arms, the abdomen, and the back. Now coming to disorders of hyperpigmentation. This hyperpigmentation can be melanotic or a non-melanotic hyperpigmentation. The non-melanotic hyperpigmentation results from the deposition of non-melanin substances which can be endogenous such as porphyrins and can be exogenous such as drugs and heavy metals. Even simple thickening of the skin can lead to a hyperchromia, which is seen in acanthosis. Hyperpigmentation is called when it is mainly due to increase in the melanin production or size of melanophages. The melanotic hyperpigmentation can be due to increased melanin or melanocytes. It is also classified depending upon the depth of the pigment, whether it is epidermal or whether it is dermal. The dermal pigmentation mainly presents itself as a slate gray or a bluish hue due to the depth of the pigment. These are other several classifications, the physiologic classification such as pigmentary demarcation line, genetic and developmental causes being lentigenes, freckles, melanocytic nevus, and cafe au lait spots. Post-inflammatory causes, eczema, psoriasis, lichen planus, lupus erythematosus, scleroderma, morphea, even burns and traumas. Infections such as tinea nigra, syphilis, yaws, and pinta, and nutritional disorders such as kwashiorkor, pellagra, vitamin B12 and C deficiency, and folic acid deficiencies. Physical causes such as trauma, radiation dermatitis, thermal burns, and post-traumatic disorders. Endocrine disorders such as melasma, Addison's disease, Cushing's syndrome, pheochromocytoma, acromegaly, and hyperthyroidism are also the causes of increase in skin pigmentation. Neoplastic causes such as malignant melanoma, seborrheic keratosis, and pigmented basal cell carcinoma. Metabolic causes include hemochromatosis, alkaptonuria, macular lichen amyloidosis, and other disorders such as pigmented purple dermatosis, etc., might lead to an increase in skin pigmentation. These are other causes being labeled idiopathic, neoplastic, genetic and developmental, inflammatory, chemicals and drugs, antimalarials, oral contraceptive pills, minocycline, clofazimine, topical hydroquinone, tattoos, etc. are all the causes of increase in skin pigmentation. Now coming to causes of diffuse hyperpigmentation. Again, the hyperpigmentation, as we have discussed in hyperpigmentation, can be localized or can be generalized. The causes of diffuse hyperpigmentation include Addison's disease, hemochromatosis, HIV infection, and several drugs such as clofazimine, chlorpromazine, amiodarone, and anti-cancer agents might lead to a diffuse hyperpigmentation. Melanocytic nevi are benign proliferation of melanocytes at the dermoepidermal junction. They can be congenital, they can be acquired. Gene mutations such as NRAS, GNAQ genes, BRFA, and HRAS genes are involved in some of the melanocytic nevi, such as the blue nevus, the acquired melanocytic nevus, and the Spitz nevi. Acquired nevi are more common, which occur later in the age, may appear in infancy or childhood, slowly grow and mature, and then regress in older life. Congenital melanocytic nevi can be small, less than 1.5 centimeter in size, can be intermediate of size 1.5 to 20 centimeter, and giant ranging in size more than 20 centimeter. The giant nevi show a potential of 4 to 6% to convert into malignancies. That can be a squamous cell carcinoma or a malignant melanoma. Excision is justified for cosmetic reasons and the risk of malignancy. The acquired nevi appear after birth any time in the later life. These are round or oval, uniformly colored, sharply bordered lesion. They can be junctional at the dermoepidermal junction, or they can be dermal, which are present deeper inside. The compound nevi is the one which has nest and column of nevus cells in the dermis along the junctional component, and these are raised, rounded, brown or black. And the intradermal nevi are the nevi which are lying in the dermis and having a neuron-like appearance. They are dome-shaped, non-pigmented, and may have coarse hairs. So the presence of hair over the nevi is indicator that is the indicator of the depth of the nevus, suggesting that it is deep dermal and requires an excision so that it can be prevented from recurrence. Treatment is elliptical excision and biopsy any nevus which shows an increasing size, discharge, burning, itching sensation over a short period of time should be biopsied. Cafe-ole macules are circumscribed round macules with irregular margins, 2 to 5 centimeter in size, present at birth. In 10 to 20% of cases, isolated cafe-ole macules may be seen. 5 or more cafe-ole macules of more than 0.5 centimeter in prepubertal age group and more than 1.5 centimeter in an adult are suggestive of neurofibromatosis. Other signs and other features of neurofibromatosis should also be searched for in such cases. A Mongolian spot is basically a pigmented blue-black lesion seen mainly over the buttocks or the lower back, and mainly it is due to the arrest of migrating melanocytes in the dermis. No treatment is required as usually it disappears by the 2 to 10 years of age. Nevus of Ota, it is a blue-gray pigmented macule on the upper half of the face. And nevus of Ito is present over the shoulder area. Both are hyperpigmentary disorders. Both are congenital dermal pigmentations. And again, the main reason being the migration and arrest of melanoblasts, which arise from the neural crest. The nevus of Ota may be associated with eyes or extracutaneous involvement. The sclera is also affected whenever a nevus of Ota develops later in life and is not associated with ocular involvement. It is labeled as nevus of Fori. Iris, cornea, optic nerve, periosteum, eustachian tube, tympanic membrane, nasal mucosa, and pharyngeal areas are other areas to be showing pigmentation. Melanoma may develop in long-standing cases of nevus of Buddha in some cases. A Becker's nevus is an acquired pigmentary hairy plaque which is common in trunk, the more common in males. It appears in the first or second decades of life. The common areas being shoulder, chest, and back. Initially, it appears as pigmented area, and later on, it may develop hair growth and varicosities over it. No treatment is needed. If at all, there is a concern. Two-switch NDR, fractional CO2 lasers can be implicated in treatment, but the results are not so promising. The reticulate pigmentation disorders of Kitamura, Dowling-Dego's disease, X-linked reticulate pigmentary disorders, the dermatopathia pigmentosa reticularis, and the dyschromatosis universalis heredita are the pigmentary disorders which show reticulate or net-like pigmentation in various different areas of the body. The familial cutaneous amyloidosis shows its occurrence in early childhood. Males are mostly affected. A generalized reticulate hyperpigmentation is the characteristic feature. It can also present as linear hyperpigmentation in blastoid distribution in females. Coarse, unruly hair and hypohidrosis may be associated with this reticulate pigmentary disorders. The dermatopathica pigmentosa reticularis is an ectodermal dysplasia syndrome, autosomal dominant inheritance, and manifesting as reticulated hyperpigmentation. Palmoplantar keratoderma, hypohidrosis, and developmental anomalies are also known to occur along with the reticulate pigmentation in this condition. Dowling-Dego's disease is an autosomal dominant disorders which manifests as progressive reticulate hyperpigmentation in flexural areas, and interdispersed can also be seen keratotic dark brown papules. Reticulate acropigmentation of Kitamura is an autosomal dominant disorder which occurs in early childhood and manifests itself as hyperpigmented, sharply demarcated atrophic macules on the dorsum of the hands and feet. Aphids or freckles are tiny, less than 0.5 centimeter, discrete brown macules, very much common in fair-skinned individuals. Usually they appear in childhood on sun-exposed parts and lighten in the absence of sun exposure. This is a point which helps it to differentiate from lentigenes, which are also similar sort of pigmentation, macular pigmentation, mainly occurring in sun-exposed as well as covered parts, and being consistently similar in appearance, not lightening with sun protection. Melanocytes are not increased in the number, but they are hyperactive. Melasma is a common hyperpigmentary disorders which occurs as macular brown to brown gray colored pigmentation areas in males and females. So many things have been implicated in etiology. Oral contraceptive pills, hormonal factors, and sun exposure are few of them. There are so many treatment modalities depending upon whether the pigmentation of melasma is superficial or deep. Being superficial, it is called as epidermal melasma, which is easy to treat. And when the pigmentation is deep enough, it is the dermal melasma, and it might involve, it might require rather several different treatment modalities for its treatment. Treatment of melasma, sunscreen for all the hyperpigmentary disorders and hyperpigmented as well. Sunscreens and sun protection are the first line of therapies. Bleaching agents of hydroquinone, kojic acid, tretinoin, arbutin, azelaic acid, etc. can be used. Chemical peeling agents such as tretinoin peels, glycolic acid peels, salicylic acid peels, triglyceric acid peels, etc. Lasers, this is Q-switch NDR laser, are commonly used. The complete resolution is uncommon, relapses are frequent, dermal melasma is very slow to respond. Fixed drug eruption is basically a hyperpigmentation disorder which occurs as a result of allergic reaction to certain category of drugs, particularly NSAIDs, fluoxetine, and the metronidazole group of drugs, barbiturates, and some antibiotics. It might occur as an area of blue, gray, or slate hyperpigmentation surrounded by erythema. At times, blisters can also develop on a lesion of fixed drug eruption called when it is called as the bullous FDE. Post-inflammatory hyperpigmentation, whenever any condition, any inflammatory condition subsides, it might leave behind a residual hypo or hyperpigmentation. Hyperpigmentation residual is more common in patients with darker skin type. Certain diseases such as lichen planus, atopic dermatitis, acne vulgaris, contact dermatitis, psoriasis, and pyodermas may leave behind residual hyperpigmentation. There is increase in the melanin in the epidermis and the dermis. The dermal pigment is usually present within the macrophages, and this phenomena is called as melanin pigmentary incontinence, and the macrophages containing this melanin pigment are called as melanophages. Treatment being, the lesions might reduce in intensity over a period of months to years. Broad spectrum sunscreen are the mainstay of treatment, and other pigmentary disorders, like other pigmentary disorders, that should be treated with topical hydroquinone, tretinoin, corticosteroids, azelaic acid, and other modalities. Now coming to the treatment of hyperpigmentation, there are several topical agents that are being used. These topical agents work on different pathways of melanin synthesis. There are some tyrosinase inhibitors such as hydroquinone, arbutin, kojic acid, licorice extract, and vitamin E. Cytotoxic to the melanocytes are azelaic acid, and other agents which mainly function by shedding of the excess skin and thereby also leading in reduction in the melanin pigmentation over the present in along the stratum corneum are alpha hydroxy acids with glycolic acid, salicylic acid, resorcinol, vitamin C, and tretinoin. Hydroquinone is a bleaching agent which is available in percentage of 2 to 4. It inhibits the tyrosinase activity. The safety concerns like irritation, exogenous ochronosis limit the use. It can be combined with topical corticosteroids, tretinoin, and kojic acid. Tretinoin is mainly used as an adjuvant to other therapies, and it mainly acts by exfoliating the skin, thereby increasing the penetration of other agents which inhibit tyrosinase or act by some other mechanism. Kojic acid is a fungal metabolite. It suppresses tyrosinase by chelating copper, which is an active ingredient, you can say, in melanin synthesis. The stability is an issue. Sensitization, irritation, potential of kojic acid are some of the side effects that can be encountered in few patients using kojic acid preparations. Alpha hydroxy acids are naturally saturated dicarboxylic acids. This lead to diminished corneocyte adhesion and thereby desquamation and increase in the keratinocyte turnover. The newer modalities such as tranexamic acid, 4-and-butyl resorcinol, oligopeptide, silymarin, botanical extracts are also widely used in treatment of hyperpigmentation, but as a sole agent, none of them is effective. These can be given as adjuncts to above discussed therapies. Physical modalities of treatment such as chemical peeling using glycolic acid, trichloroacetic acid, salicylic acids, and use of lasers are widely used in the treatment of hyperpigmented disorder. The Q-switch anti-arc laser, 1064 nanometer and 532 nanometer, the helix dendrite laser of 755 nanometer, the pulse dye laser, and the intense pulse dye light are various modalities which are being increasingly used in treatment of hyperpigmented disorders. Thank you. So this was an overview of disorders of pigmentation, hyperpigmentation, as well as hypopigmentation. Vitiligo, being a disorder of depigmentation, is dealt with separately in another lecture that we will be covering in another topic. Thank you so much.